Well, thank you. Now let's go on to the topic of the most recent FDA approval of olaparib in the BRCA mutant metastatic patients. So I guess it comes into the context of how we've been treating these women anyway. You know, we've been treating them, and you know, we've known that they have BRCA mutations, that we're in the metastatic setting, let's say. What kind of approaches have you've been using, you know, Nadine? We'll get also to the preoperative, which is a bit of a conundrum, you know, with regard to the BRCAs. But in the metastatic setting, what kind of data do we have, you know, with regard to chemotherapy?
Okay, so for chemotherapy, I think what Tiffany was alluding to is we do get some sense about different responses to chemotherapy, and I think the TNT trial is probably the one to start with and to talk about. So the TNT trial, if people remember, was a randomized phase 3 trial for patients with triple-negative breast cancer, but also for those with a germline BRCA mutation. So in that study, there were 43 BRCA carriers. Most of them had triple-negative, 31 of them. There were a few ER positive, but 43 BRCA carriers. And the study was a randomization in the first-line metastatic setting to either platinum or to docetaxel, carboplatin. And at progression, there was a crossover, and there was always a pre-planned analysis by BRCA status. So the take-home message in that study was that overall, there was no advantage. There was no difference in response rate or progression-free survival between the platinum or the docetaxel, except for the germline BRCA carriers. They had a significantly better response rate and a bit of a better progression-free survival. So this confirmed older, smaller studies that showed that platinum seemed to be more active among the triple negatives in those who had a germline BRCA mutation, and that it was better than docetaxel and better than those who didn't have a BRCA mutation. So platinum's an active agent. There's no doubt about that. I think the question then becomes, is platinum better than standard chemotherapy? Is it better than anthracycline-based regimens? And I think we don't have a direct comparison to answer that question. I think the only other data to me that speaks to it in some prospective way are studies like gBRCA1. So this was a study in the neoadjuvant setting for triple negative using a little bit of a different regimen, but a weekly anthracycline, a weekly taxane, asking how much benefit did you get if you add the platinum? Do you get a better path CR, better disease-free survival? And interestingly, if you look using the standard therapy, you look at the BRCA carriers, there were 50 of them, versus those without the mutation, the path CR rate was much higher in those with BRCA mutation standard therapy, 68 versus 33% path CR. So standard therapy is very sensitive in the BRCA carriers. If you asked, did the platinum add anything, it only added for those wild type, those without the BRCA mutation. So one interpretation of all of this is that BRCA-associated breast cancer is more chemosensitive. Platinum is active, standard therapy is active. Until you compare them head to head, you don't really know which is better. And we're actually conducting a study like that in the neoadjuvant setting, just comparing cisplatin to AC. And I think that will provide some data even in the ER-positive BRCA-associated breast cancers for which there's no platinum data at all. So I think chemosensitive tumors is what I would say at this point.
Mm-hmm. And that's really interesting. We don't have a whole ton of data in the metastatic setting with regard to chemotherapy, but the TNT with carbo was really a nice level 1 evidence, albeit a small subset. But that really is interesting about the gBRCA1. No additional benefit from the addition of the carbo in path CR or disease-free survival in that population. How about in the metastatic setting with the BRCA patients, you know, kind of heretofore, before olaparib came along, you know, for example, did you kind of prefer to start with a platinum or not necessarily, or?
I think that it's been somewhat evolving. These patients often in the early stage setting would have received an anthracycline, a taxane. They may have received a platinum. In the time of CREATE-X, they may also have received post-neoadjuvant therapy with capecitabine if they failed to have a path CR. So a lot of this is the art of medicine. It depends on what they've previously seen, how long of a disease-free interval did that patient have. But I think that taxanes, platinums remained really a first-line option. And personally, I found I was moving eribulin up sooner in the metastatic disease course for these patients as well.